Welcome to Navigating Your Carrier EOBs and Provider Statements. Again, my name is Arwen. Oh, there's the disclaimer. We already beat that dead horse. My name is Arwen Robinson. I am the Director of Marketing here at Advanced Benefits. And so from time to time, I get an opportunity to share some great information with you. So today we're going to go ahead and as far as the agenda is concerned, we've got a couple really important items to go over today. So first of all, when it comes to navigating your explanation of benefits and your bills, it's important to know what these terms mean. And unfortunately, this process does not use layman's terms by any stretch of the imagination. They're all very, very technical. It can be very difficult to understand. And so we're going to go over that information. We're also going to go over the flow of claims to better understand exactly how it works from the time that you access services or fill a prescription to the time that you get your bill in the mail. We're going to talk about the different areas where the system can break down, where there's pitfalls in the processes, and how to advocate for yourself so that you are not finding yourself in a situation, or if you find yourself in a situation where you are on the wrong end of a process gone wrong, you know where to start to get into a better spot. And then lastly, we're going to talk about if all else fails, what does it look like to engage with a claims advocate? Okay. So first things first, some key terms. It can be very, very difficult to navigate the different understanding your bills and your EOBs for terms that you just want them to say, just tell me what you mean, what makes sense. And so we're going to talk about what it means if you have a bill charge, what network savings looks like, deductible, not covered, co-payments and co-insurances. There's a lot of confusion often about that. And then amounts paid and patient responsibility. Okay. So first things first, when it comes to your bill, you're going to look at the initial charge. Okay. So the initial charge is going to be what was the insurance company billed from your provider. So a provider in this case is going to be like a doctor's office, a facility. It could be a dentist. It could be an optometrist. It could be a pharmacy. Whoever is rendering services is going to bill their amount to whoever it is, the insurance company, the pharmacy manager, whoever that is. Now, it's important to know that what a provider bills insurance might be different some situations than the cash price. So I usually recommend ask what a cash price is for a service first, and then asking, well, how much are you going to bill my insurance? Because sometimes it's cheaper to do a cash rate. So the initial charge, how much did the provider bill the insurance company for the services I received? And here on the right-hand side, you can see we're going to work with a billed charge for $5,000. Okay. The next thing is network savings. Now, with this situation, it's kind of 6 of one, half a dozen of the other. There's two terms to keep in mind, but they mean the same thing. So if you get billed $5,000, or your insurance gets billed $5,000 for, let's say, a surgery, for example, you might look at your statement from your provider, and it might say, okay, the allowed amount was $4,500. Basically, that means that when the provider billed for your surgery, because there's a contractual agreement, the insurance company says, hey, you're only allowed to bill our members $4,500, right? So that other $500 difference, you got to write that amount off. That's the discounted amount that you get just by being a member of the insurance company. So that's called an allowed amount, is, that discounted rate. You can also hear it called a contractual adjustment, and that's usually what it's called when you see it on your billing statements. So if you see a bill charge for $5,000 and there's a contractual adjustment of $500, that means that they're discounting $500 off. Ergo, the allowed amount is $4,500. So you can kind of hopefully see how an allowed amount of $4,500 or a contractual adjustment of $500, these mean the same thing. It means that the provider is having to write off $500, okay? So now that we have a bill charge and the network adjustments have happened, now the next phase you're going to go into is your deductible. Now, your deductible is how much money needs to come out of my wallet, my bank account, whatever that is, before the insurance company starts to help me out. It's my, basically, what do I have to pony up before the insurance company starts to pony up as well? So in this example that I'm giving you, this example is a $2,000 deductible. So if I have a $2,000 deductible, the first $2,000 of any charge that is going to happen that year is on me. So after I've had $2,000 come out of my wallet, now I can expect the insurance company to start helping me out. So now we're working off of a member balance. So far, I know my member balance is $2,000 because that's my deductible. That's what I'm on the hook for, okay? But what about that's a big difference between 4,500 and 2,000. So how does this break down? How can I expect this to continue to play out? So the next phase that we look at a doctor's bill statement, whatever that is what's not covered, okay? So if something's not covered, this might be a situation where it's something that is truly not covered by the insurance. An example might be teeth whitening, right? If I go to the dentist and my dentist does services like fillings, cleanings, and then I also opt for like a teeth whitening tray. If I were to get my EOB back from my dental insurance, they would say, hey, that teeth whitening is not covered because it's considered cosmetic, for example. So that would be one of those situations. There also might be a situation where the insurance company says, hey, this is something that, you shouldn't be billing for, so you have to write that amount off. So basically, if it's not covered, that's what it really matters. Is this an in-network provider? And this is something that I'm going to see them either write off or I'm going to get billed for because it wasn't medically necessary. Or is this a situation where this is an out-of-network provider and they're going to balance bill me that amount? Now, I'll talk a little bit more about balance billing in just a bit. So now I know that I still have that $2,000 deductible, $50 wasn't covered. In this example, we're going to assume it's an in-network provider. And so this $50, they're going to eat that. They're going to write that off. Okay, coinsurance. So after I've met my deductible, right, I had to pony up the first $2,000 for my surgery. Now what happens? Well, now the insurance company is going to come to the table and they're going to say, okay, we're going to start paying for a certain, a percentage of your claims. Now, depending on what kind of insurance you have, that split can be different. When you think of coinsurance, think of the word co-pilot, right? I'm co-piloting the bill with the insurance company. So a lot of times for really traditional plans, we'll see it be like a 20-80 split, right? Where I, as the patient or the member, pay for 20%, the insurance company pays for the other 80, and they pay for most of it. I've seen 20-80 splits. I've seen 30-70, I've seen 50-50, and there are very rare instances, less rare nowadays actually, that your deductible is the same as your out-of-pocket maximum. And so once you meet your deductible, you're all done for the year because you've met your out-of-pocket. So, but again, most common I see 20-80, 30-70s pretty frequently. Every once in a while I'll see a 10-90, but those plans are pretty rare. So basically, I have this amount, and if I look at the difference between $2,000 and $4,500, and I'm on the hook, in this example, the coinsurance is 20%, this $890 is my 20% responsibility, okay? So the insurance company was billed $5,000. I might be looking at $5,000 and starting to sweat, saying, I can't afford $5,000. Well, once you've met your deductible, and you've paid your portion of the coinsurance, your member balance comes down to $2,890, okay? And let's say if I were to be billed for another surgery, another $5,000 surgery, I've already met my deductible. So now it's just going to be that split right away. So we can see that as soon as your deductible has been met, that's when you're going to start to see the insurance company start to make those payments. All right, amount paid. This is one where I think there's the most confusion is when you have insurance, right? You say, oh, well, I pay for insurance, so they've got to cover me. And so if you haven't met your deductible, that amount paid is going to be zero, right? They're not going to pay for anything until your deductible's been met. And that's why I see a lot of frustration and aggravation around, well, why do I have this insurance? They didn't pay for anything. And that's where I remind people, hey, if you haven't met your deductible yet, what you really care about are those contractual adjustments, that in-network savings, right? How much are you saving just by having the insurance, right? Just by putting your member ID card down, you're saving money just automatically getting those in-network discounts. And so even if you haven't met your deductible, you're still getting love from the insurance company. And once you've met your deductible, not only are you getting love from a discount perspective, you're also going to start to get love from them when they're picking up their portion of the co-insurance. And so in this example, the insurance company paid the $1,560. All right. So that pulls us to that full circle of that $4,500. All right. So then we shake out to a patient responsibility. And so when you get an explanation of benefits from the insurance company, you see all of these charts and graphs as far as, well, how did this get broken down? But what we care about the most is that patient responsibility, right? Now, when you get an explanation of benefits from the insurance company, right, it says on it, explanation of benefits, this is not a bill. The reason that you get that is because that's their explanation of how did we process this claim, right? What were we billed? What discounts did we give? What did we apply to your deductible? What did you have to pay for your coinsurance? What amount was not covered? What amount did we pay? That all trickles down into a patient responsibility, but it's not a bill. The bill is going to come from the provider's office that rendered the services. So you are going to get a bill either from your doctor's office, facility, dentist, optometrist, chiropractor, wherever you're accessing services, or that's where the bill is going to come from. I have a really great question in the chat that I want to address. Actually, it's very, very timely. So the question is how is the coinsurance calculated? Is it calculated based off of this allowed amount, or is it calculated for the remaining balance? The answer is it's calculated for the remaining balance. So the first $2,000, if I have to meet my deductible, that is my responsibility right off the top. And so once I pay the first $2,000, the remaining balance of this, so $2,500, that's when they're going to do the math of, okay, what's your 20%? What's your 30%? What's your 50%? So the deductible has to come first. It comes right off of the top. So that's a really great question. I appreciate that. Okay. So now let's go ahead and let's dive into some examples. Now, of course, we have HIPAA, which is your protection for your private personal health information. But this is my information, and I give myself permission to use myself as an example. So rest assured, if you're seeing this information, it's not a client or a client's employee of ours. This is my information, but I am going to black it all out so that you can say, oh, well, now we don't have Arwen's personal information. Okay. So here's an example. This is a screenshot of my explanation of benefits that I received from my insurance company. Okay. So I went in on May 24th and there's a line item for surgery. All right. So I can see here the amount billed by the provider was $221, right? Remember that very first number that kicks off the whole process? What did the insurance company get billed from my provider? So there's that amount not covered, right? This whole thing was medically necessary. I didn't have anything that wasn't necessary or wasn't covered. So, and my discounted rate, you'll see, look, this discounted rate is the exact same as what was billed by the provider. That's okay. That means that my provider didn't overcharge for it, right? If my provider had billed, let's say, $521, I would have seen this 221, which meant that they would have had to write off the other $300. Because these numbers are the same, that indicates to me actually something really positive. It means that the provider and the insurance company are in really close alignment with what is a fair price for the service. They didn't overcharge or try to get more money out of the insurance company. So that's totally fine. I'm happy with that. Amount we paid, $0. The insurance company has not paid for any of this service because I haven't met my deductible yet, right? I have, for my family, I'm on a high deductible plan. I have a $5,000 deductible, which I'm totally okay with for other reasons. So this $221, not surprising, I haven't met my deductible yet. So all $221 applied to this deductible. And so what it tells me is I owe, and I am probably going to expect to get a bill from this provider for $221. Now, the important thing is when you get a bill from your provider and your explanation of benefits from the insurance company, when you hold them up side by side, they should match. What the patient responsibility is on your explanation of benefits is what your patient responsibility is on your statement. So you'll want to look at that really closely, line item by line item, and make sure. Now, keep in mind, there might be an instance where it doesn't match because your provider is giving you like a one lump sum. They baked it all together and they gave you a summary total, whereas this is going to show you every single line item. So we're going to talk a little bit later about the importance of requesting an itemized bill. So there's one example. Here's an example of one of my statements that I received from my provider, right? So we've looked at the insurance side, looking at the explanation of benefits. Now we're going to look at the provider side, looking at the bills that we're receiving, okay? So this is for a different service, different date. So I went in and I had an ENT follow-up, right, with the ear, nose, and throat doctor, making sure that my ear balls work. And so I can see here that this service, what was billed to the insurance company, was $250. That's how much was billed to insurance, right? Did insurance pay anything? No. The insurance payment was $0 because, again, I haven't met my deductible yet. They're not going to pay for anything until that happens, right? But just by putting down my member ID card, just by being a member of that insurance company and going to an in-network provider, that means that I'm getting a discount. They knocked off $138.76. So if I were to look at this and I were to go, oh, insurance didn't pay anything. God, why do I have insurance? Well, I have insurance because while insurance didn't pay anything, they sure discounted quite a bit of it. So I am much happier paying $111.24 for this visit than I am paying $250 for this visit. Now, I talked about in-network versus out-of-network in balance billing, right? So if I'm going to an in-network doctor, this $138.76 that I got as a discount, when the provider gets that information, that $138.76, they have to write that off. They're not allowed to bill me for that, right? That is what the insurance company says. Hey, you contractually agreed that you are not going to charge our members more than that $111.24. So you billed more than that. So sorry. That's, less of what you get. And that's why if you have friends or family, or if you yourself work in healthcare, this is a big point of frustration and contention at times in the healthcare system, is that agreement, the contractual agreements between the insurance companies and the healthcare providers for, well, how much does it actually cost to render these services? How big of a discount am I expected to give, right? It's a big point of that where attention can occur, right? Now, if I went to an out-of-network provider, right? This is a provider that says, nope, I don't accept your insurance. If you come to me, I'm not billing your insurance. You have to take care of it yourself, right? If it's an out-of-network claim, what would happen is they would say, hey, we're going to collect $250 from you. And I would submit the claim to manually by myself to the insurance company, and the insurance company would say, hey, we only cover, the allowed amount for this service is $111.24, which means that this provider is going to collect the $138.76 from me out of my own pocket, right? I don't have that discount protection if I go to an out-of-network provider. That's called balance billing. When they bill you, the balance between what they would charge and what the insurance would cover, right? So that's why it's so important to make sure that you are accessing in-network providers whenever possible so that you can take full advantage of those discounts. All right, let's get a little bit more complicated. We had a busy year in my household for healthcare. Okay, so this is a much more a larger example. This is a cataract surgery that somebody in my family decided was a good idea to need. I mean, eyeballs are important. I get it. So here are some screenshots that I took of not just the bill, but I also was provided with information from the provider's office on what I could expect them to bill. So forgive my chicken scratch. Over here on the left-hand side, I'm an insurance guru. You can be too. I asked them up front, hey, I want to know what this is going to cost me. I need the insurance billable CPT codes. These are the codes that healthcare billers use to bill insurance companies for, and there are over 10,000 CPT codes for every little line item. There was one time in our office that we fell down a rabbit hole and we found that there's a section of CPT codes that is for bites from different animals. There is a CPT code for if you're bit by an alligator versus if you're bit by a possum or a turtle. It's a crazy world out there, but there is a CPT code for literally everything. So, not shockingly, I was able to get my hands on the CPT codes, and they said, hey, these are the things that we would possibly bill for. We won't know exactly what we're dealing with until we get into the eyeball, right? So is it going to need a stent? Are we going to do an IOL? Right? That to me was provider. I didn't understand that part. But what I did understand was, hey, these are the possibilities, right? We're for sure going to bill for anesthesia. We're for sure going to bill for these things. But these are the 4 possible outcomes depending on what happens once we get into that surgery, depending on if it's going to be simple or if there's a complication. So I was able to work with my insurance company, use their cost estimator tool to get an idea of how much these were going to cost before they happened. And then in turn, once I got the bill from the provider, and so this is broken out into each phase, right? So this isn't just one lump sum where it says eye surgery, right? It's showing, the different things. So I've got here are the charges. Here's how much the insurance company was billed by the provider. Now we can see over here in payments, big fat zeros. Insurance didn't pay for any of this. Why? Because I haven't met my deductible yet. I'm very close to meeting my $5,000 deductible, but not quite there. But what I really care about is over here. Look at the adjustments that I got for just by being a member of the insurance company and by using my ID card. So for this office visit, instead of getting $333, I got charged $251 because they said, hey, you're going to get an $82 discount, right? Same thing here. I was going to pay $60. They knocked off $13. I'm paying $46, and so on and so forth. What I really loved is this one right here. Instead of paying $16.58, I paid $729 because they knocked off $928. These two numbers made me pretty happy, right? That's That's $1,600 more that I did not want to spend on this. So when I'm looking at this, I can expect to receive a corresponding explanation of benefits from my insurance company that should have each thing that happened. It'll show me right back to here. It'll show me how much was billed, how much did they discount, how much did they apply to my deductible, and what do I owe. This what do I owe grand total should be the same as this 2506 balance due. So even if you haven't accessed services lately, this is a great exercise to familiarize yourself with. The more comfortable you can get at understanding how to read your patient's statement, the less scary, the less frustrating, the less confusion there will be, right? Those three things, confusion, frustration, and fear, those are often gathered around things that we don't know enough about. And so if you're, and this is, as you can see, this is $2,500. This can have huge financial implications for your household. So the sooner you can understand and have some level of confidence in how to interpret and digest this information, the sooner you can know if something went wrong, right? Are you being overcharged for something? Did something not get billed to insurance? All this stuff. This is the kind of you need to know what it looks like when it was processed correctly so you can identify when it is wrong, okay? So let's talk about what can go wrong. Oh, one thing is if you were to ever need like a cheat sheet, if you've registered for this webinar, one of the follow-up emails you'll receive is a copy of this slide deck. If you needed a cheat sheet, this is what I recommend that you print out. It's a wall of text, but it's your quick reference guide on, okay, what does this mean? What does that mean when you're digesting? Even if you have this sheet up next to you while you're looking at your bills and your EOBs, this should be a very helpful tool for you. All right. Let's talk about the flow of claims. So I've got 3 instances here of how does this process work, because I want to teach you where in the process can things break down. Okay, so let's take a medical claim as our first example. So the very first step is you as a member or a patient, depending on who you're talking to, seeks care and accesses services. So in this example, right, previously, I have a cataract and I need cataract removal surgery. I'm going to go seek care. I'm going to go have that surgery. The provider is going to render the care and is going to chart the billing codes. And so if I'm, at a surgery center and I'm going to get a cataract removal surgery, they're going to render the service. And then the doctor is going to say, hey, this is what we did. Therefore, here's the CPT codes that we used, right? Remember in the earlier slide, they had the list of possibilities. After that surgery, they're going to say, this is what happened. It wasn't complex. It was simple. This is how much time it took. They're going to know exactly what those CPT codes should be. They're going to bill the insurance based off of the charted notes of what happened and what the corresponding CPT code should be. Insurance is going to receive that information, and then they process the claim. Now, by processing the claim, this might mean that it's just, I didn't say they pay the claim, it's just processing it, right? They're figuring out, have you met your deductible? Are you in co-insurance? Or is this an in-network provider and we're going to apply discounts, right? They're going to go through their process. And then once they process the claim, they remit details to the provider so that the provider can prepare their bill. And they're going to remit details to you as the member on how they, as the insurance company, processed the claim. And that's where you're going to see that chart that breaks out each little piece. And then lastly, you as the member are going to receive your bill from the provider and the corresponding EOB. And again, if it goes well, those should match, right? What does it look like if I'm filling a prescription? Well, it looks a little bit different. So if I go to fill a prescription, and this all happens pretty much instantaneously because they are using systems that talk to each other in real time. So if you go to the doctor, they say, hey, we're going to issue you this prescription. I know more and more providers are moving away from writing the prescription on the little pad for lots of reasons, security being one of them. So more often than not, your provider is going to say, we're going to call in this prescription for you. What pharmacy would you like it called into? So I might say, I want it called into Walgreens or Walmart or Rite Aid, right? So the provider is going to submit the prescription order to the pharmacy. The pharmacy is going to ping the insurance company and says, hey, we've got a member of yours that has a prescription here that wants to be filled. The insurance company uses call it a department, right? They have an entirely different branch of their insurance company that handles pharmacy claims. And that is called a pharmacy benefits manager, or PBM, right? So if you have you ever called the 1-800 number for an insurance company and they say, if this is a medical claim, press 1, if this is a prescription, press 2, that's because they're going to two completely separate entities or arms of the insurance that access completely different systems typically. So they're going to say, hey, this is a prescription. We're going to kick it over to our pharmacy benefits manager. And you can see there's more and more hands in the cookie jar, which just tends to muddy up the water sometimes. So the pharmacy benefits manager is going to look up the formulary to determine the price. What is a formulary? Well, if you've looked at your benefit summaries, you're going to see generic, preferred, generic, non-preferred, preferred brand name, non-preferred brand name, specialty, non-preferred specialty. There's all these categories that your prescription could fall under. Those categories is the formulary. And I think of it as the formula. They've come up with a formula of which prescriptions are generic, which are brand name. It's important to know every insurance company is different. A brand name with one insurance company might be considered a generic with another insurance company. It all comes down to what they have negotiated with the manufacturers. So that's something to pay attention to. If you change from one insurance company to the other, what impact is going to be made to your prescription in the formulary, okay? So the pharmacy benefits manager is going to look up the medication and they're going to look at the formulary to determine the price. So an example I like to use is a common cholesterol medication, Lipitor. And Lipitor is usually a brand name medication in formularies, right? I say usually because not always the case, but it usually is. And so a brand name medication might have a $50 copay, perhaps, if you're on a traditional plan with copays. So they're going to say, oh, this is $50. If you're taking the generic form of Lipitor, which is either like simvastatin or atorvastatin, those are usually generics and could be $8, $10, $12 instead. And so that's where this step right here is really going to matter. And you, as they are empowered in this step, right? The pharmacy benefits manager is going to tell the pharmacy how much you, as the member, should be charged for the medication. And so if they're going to charge you $50 because it's a brand name, you have an opportunity to seek out generic alternatives so you can pay less, right? So in the flow of the claims, the pharmacy benefits manager tells the pharmacy, here's how much you need to charge this member for the prescription. And then they and the insurance company hash it all out on the back end. And then the pharmacy collects payment from you and dispenses the prescription. Okay. Now, the last flow that I want to talk through for you is prior authorizations. Now, what is a prior authorization, you may be asking? So if in the case here of the, cataract surgery, in my household, this surgery was for somebody under the age of 50. So it was very, very unusual that this member would need a surgery of this nature at a very young age. And so they said, hey, is this really medically necessary? And this is the insurance. The insurance said, hey, is this medically necessary? And there are situations where prior authorizations are standard operating procedure, right? There are surgeries, services, lots of imaging services, where it is part of the process that a prior authorization must be submitted and approved. There are some situations where it's a one-off, depending on the circumstances, right? In this situation, this was a very young person having a surgery that is very expensive and is out of the norm. So this is a mechanism that the insurance company has to give themselves an opportunity to deny care that is either not medically necessary or they want you to seek alternative treatments. This right here is where another big point of tension can occur in the healthcare system. Now, make no mistake, the healthcare system is, in my opinion, this is a personal opinion, very cobbled together, right? There are systems that and processes that are constantly coming out and changing, and they grind the gears of other processes and other things. And there's people out there in healthcare, in dentistry, in optometry, that in physical therapy, that just want to care for their patients, but they keep getting added on administrative burdens over and over and over again. And so this is one of those pieces that is a point of frustration for providers that I'm a doctor, I went to medical school. I feel like I would know if this is medically necessary. But there's the flip side where there are documented instances that we'll see in the news of abuse, where providers will have back surgeries instead of trying physical therapy, right? Though there's lots of cases out there. So it's this balance, and there's no silver bullet here to find, well, this is what works. They just have this process in place, and some people need it, but the most of us, it just adds extra work, right? So they say, hey, I'm a doctor. I need to have this surgery done on my patient. The insurance company, I would like permission to have this service and have you cover it. So the insurance company is going to review the request against medical necessity guidelines. Again, back to that tension piece, I hear some of my clients or employees will say, oh, you've got people in a call center that don't have a medical degree that are practicing medicine. That's something I hear a lot. It's important to note that these medical necessity guidelines, they are established by a doctor. Each insurance company has a medical director, medical committees that review these things, and they create the policies and they say, this requires a prior authorization and this is medically necessary. And that is distributed to the team, but the team that is relaying that information, they themselves are not doctors, right? But I want to, provide at least that consolation that there are doctors that are looking at this information. So in this instance, this might be somebody that says, hey, my patient needs back surgery, but they haven't tried a lick of physical therapy. And this is one of the situations where you should try physical therapy first. They're going to review that. Or they're going to review a prior authorization for, hey, I have a 30-something-year-old patient who is going blind prematurely and needs cataract removal surgery. The insurance might request additional information from the provider, such as imaging or chart notes. So in the back surgery example, they might reach out to the provider and say, hey, can you provide us with documentation saying that you've tried physical therapy and it didn't work on this patient? Or there's more context as to why physical therapy doesn't work for this patient. In the instance of cataract surgery, they said, hey, can we see a copy of the image that you took of the eye seeing the cataract? And they went, whoop, that's a cataract, all right. So the insurance will either approve or deny the procedure, right? Cataract surgery, they said, yep, that's a cataract. That stinks. Sorry about your bad luck. Have fun in surgery. Or they might deny it and say, hey, this is a back surgery and you haven't even tried any physical therapy. You haven't tried cortisol shots or anything like that. Maybe try that first before jumping straight to going under the knife. Okay. If it's approved, the services are rendered, right? So then cataract surgery happens, they bill insurance checks and says, yep, this was approved. We're going to go ahead and process it. If it's denied, members are given the opportunity to appeal. Now, it's important to know that appealing it isn't just going back to them and saying, please, because you only have so many appeals you can make before you're not allowed to make an appeal anymore. So don't waste your appeal on just asking, please reconsider. Anytime you make an appeal, you want to come back with documentation. So, if for some reason they say, like, let's pretend that they come back and they say, no, you're not having back surgery. Okay, well, here's documentation of when I did physical therapy 5 years ago for an entire year and it never improved. Here's more documentation showing that I have had cortisol shots and it didn't work. Here's documentation showing that I tried all these other things. And here's documentation saying that this surgery is recommended by Johns Hopkins University to treat this. And here's the article of why this is so successful and has such a success rate. That's the kind of information that you want to include in your appeal, because again, they're looking at medical guidelines set forth by the medical director and the medical committee within the insurance company. So it's important to know that your appeals, the amount of appeals you have are limited, and the more documentation you can provide an appeal, the better. All right. So now that we know how this all flows, where do things break down, right? A lot of times, this is why people call us at advanced benefits, is something went wrong. So here are the kind of things that can go wrong. Now, I want to preface this with, this is not me beating up on healthcare providers. Like I said earlier, the system is so broken, has been so cobbled together that these providers, I am hearing more and more providers say, I got into medicine because I wanted to help people and I am drowning in paperwork. I hear that a lot. There's more and more providers that are moving away from a traditional healthcare model, and we hear a lot more of like the concierge doctors, right? These are doctors that are getting out of medicine entirely. And so I think it's important to know that nobody is sitting in an evil tower twirling their mustache thinking of how they can be evil to people in healthcare or to members or to patients. I think that these are people that are doing their best in the situation they're in. They're not set up for success. They're overburdened administratively, and they're just trying to do their best to help their patients and keep insurance companies happy, which is a balancing act that I don't think anybody has successfully achieved yet. But accidents, mistakes still happen. It's still important to know where those accidents and mistakes can occur so you know what to look out for, okay? I'll get off my soapbox for now. So what can happen from the provider side? They might bill with an erroneous CPT code that's not covered, right? So it's not unheard of, right? If you're typing a bunch of numbers on your keyboard to fat finger it and grab the wrong one, right? And the insurance company might say, this isn't covered. And if you didn't look closely at it, you would just be told, oh, it's not covered. Well, did you bill the wrong thing? Did you bill me a bite for an alligator, or did you bill me a bite for a turtle, right? Two very different things, only one number away. They might bill under an erroneous tax ID number. Now, here's a situation that we have where I live. I live in an area with two hospitals very, very close together. Did you know that a provider can work out of both hospitals? So there's doctors that on Mondays and Thursdays, they work out of hospital A, and on Tuesdays and Wednesdays, they work out of hospital B. Maybe they're only in network at hospital B, but the biller might accidentally bill it under hospital A. So it's important to keep in mind that these tax ID numbers are they have either tax ID numbers or what's called NPIs, National Provider IDs or something like that. If they're billed under the wrong one, it might suddenly say, this is out of network. And you go, no, this is in network. Did they bill with the right one? Providers might fail to bill insurance altogether. That's something that I see happen. The biggest way to identify if something hasn't been billed to insurance is if you do not see any adjustments. If the adjustments are zero and the payments are zero, and you don't see any information on there about your insurance, they might not have billed insurance. They might have failed to submit a prior authorization, right? There are, like I said, there's some instances where prior authorizations are standard operating procedure. And so they know that, oh, this needs to happen. But there are some situations where it triggers a prior authorization due to special circumstances, right? Like a young age for a cataract surgery. If that person in my household was over the age of 50, they probably wouldn't have looked twice at it. But because he's under the age of 50, they went, really? So it's important to know that the providers need to be paying attention to whether prior authorization is required or not. Or remember how I said earlier that the insurance company might come back and say, hey, we need a little bit more information about this before we approve the prior authorization. I've had a couple instances where we've reached out to providers and said, hey, what's the hang up? Why isn't this moving forward? And the follow-up request for more information was never addressed or never went anywhere. So these are some areas where mistakes can occur. And as a member, as a patient, it's very helpful to be aware of this is what can happen, so you know what to look out for. Now, on the provider or the pharmacy side, right, what's other things that can go wrong? They might look under the wrong or terminated policy. Maybe you had a policy with them. Let's call it Cigna, for example. You might have had a policy with Cigna last year at your old job, and now you have a Cigna policy under your new job. And they say, sorry, we can't find you. You don't have coverage. Well, are you looking at the old policy, or are you looking at the policy that I have now? They might fail to notify a provider additional information is needed. I've had this happen where I follow up with the insurance company. They say, oh, we have a prior authorization. We requested more information and we never heard back. And I said, okay, can you please confirm the date and the time that you requested more information? And they said, oh, it looks like we updated the system, but we never notified the provider. That can happen. Or if they do request follow-up information, and they say, oh, please fax a copy of the MRI to this fax number, right? That fax goes into the insurance company. And when we follow up and say, hey, the fax was sent, did it get forwarded to the right person? They say, oh, no, it looks like it accidentally just sat in the inbox and didn't get sent to where it needed to go. So again, it's a very, very broken system. It takes a lot of due diligence and a lot of follow-up to make sure that it doesn't go sideways. Okay, let's bring it home. So advocating. So I've talked about here's how to interpret your EOBs and your bills. Here's what it should look like when it's done correctly. Here are areas that could go wrong. Now something wrong has happened. Now it's time to step up to the plate and advocate for yourself and say, hey, this is wrong. You're trying to bill me for more than I should pay. No, that's not happening. What can you do? So the number one thing I always say, request an itemized bill. Make sure that if you are going to advocate for yourself, that you request an itemized bill from the provider. That doesn't mean that you're going to get a summary that says services, grand total. It's going to be like that other bill I showed you where it's line item by line item. Here are all the things that happened. Here are all the charges. Here are all the adjustments. Here's all the payments. Here's what you owe, right? You want all of that information. I say get an itemized bill that has the CPT codes on it. Look for upcoding or services that were billed that you never received. Sorry, I'm fighting back a tickle in my throat. So what is upcoding? Upcoding is instances where the CPT code that gets billed is of greater severity or is more expensive than a lower CPT code. So an example of this is if I go to the emergency room, there's different levels of what is my emergency. If I go in because I have a cut on my arm that needs stitches, but I'm not bleeding out, I'm okay, I'm just going to hang out there and I'm just applying pressure to the wound until I can get my stitches, that's going to be a lower level emergency room visit, right? So that CPT code should reflect accordingly. If I go in because I've been in a horrific accident and I've got bones poking out and I'm bleeding out, that's the top level, right? I need services right now. I am going to die unless I get services instantly, right? That's the top level. And if, as you can imagine, the most expensive. There have been instances where people get their bills from the emergency room for things that were not super big deal, and they got billed at that, oh my gosh, you're going to die level, because it's more money for the hospital, right? That's an example of upcoding. And so you can look at that and say, hey, you billed me for a super duper emergency, and this was not a super duper emergency. This feels a little fraudulent. I'm going to need you to fix that. Another example of upcoding is time, right? So doctors will bill in increments of time. Sometimes it's like increments of 15 minutes or 30 minutes. I've seen instances where a member was billed for something that was an hour that only took 15 minutes. That was an upcoding, right? It's more money from the insurance company, but it's also more money out of my pocket. And so I called and said, hey, this was not an hour visit. This was a 15-minute visit. I need you to change the CPT code to be more in alignment of what actually happened. Okay. So those are some things that can happen. Scrutinize inpatient versus outpatient care. Inpatient means I'm in a hospital. Outpatient means I'm at urgent care, an outpatient surgery center. I'm not admitted into a hospital. Inpatient care is wildly more expensive. So if you were not admitted to the hospital, it wasn't inpatient, it should be an outpatient charge. Like I said earlier, one thing I do is I ask for CPT codes in advance, if that's the kind of situation where if it's like a planned service or a planned surgery. Obviously, if it's an emergency, get the services. You'll worry about the CPT codes later. Other recommendation I have for advocating for yourself is document. Okay. If you are having a tough time and you're getting the runaround, it's not uncommon to be told one thing and then be told another and then be told another. And this is your finances. You need clear answers. And so in what we do, we document the snot out of this. We document, and this is really important, if you call the insurance company or if you call the provider's billing office, document who you spoke to by name, what time you called in, and what day you called in. There have been instances where I'll take notes and I'll say, I talked to so-and-so on this day at this time. They told me this. I document it. I call back later and say, hey, I'm following up on this. And they say, oh no, this, that person was wrong. Okay. I've had instances where I've had the insurance company pull the recorded call and I say, that is not what you told me. I am holding you to what you told me. But unless I have that information of who, what time, and what date, I don't have a lot in my arsenal, right? So document everything. If you can, ask for something in writing, right? Hey, so-and-so, you sent me the CPT, you had me write down the CPT codes. Can you email those to me actually so that I can have them for later reference, right? Try to get things in a written form as often as possible for documentation purposes. And be proactive. It is so easy because this can be big and scary and frustrating again, and it's big and scary and frustrating because we're not familiar with it. Be proactive, familiarize yourself with it, because if you get medical bills, they don't, and you put it off because you don't want to deal with it right now, they don't go away. They will go to collections, and it is very, very difficult to reverse and unpack what happened if it's in collections, because as soon as that happens, the insurance company says, we're done with it. And the billing office at the provider says, we're done with it. So don't let this get away from you. If all else fails and you've navigated your healthcare, you've looked at your EOBs, you've looked at your bills from your provider, and you're getting the runaround, and no matter what you do to advocate for yourself, nothing is coming together, you do have access typically to claims advocates. This might be a third-party service that you have as part of your employee benefits package. It might be because you're a client of Advanced Benefits and you're engaging with our claims advocacy team. If you engage with our claims advocacy team, this means that you are calling in some backup and some reinforcements. You're asking for more players on your team to tap in and to help you with this situation. Oftentimes, a claims advocate has relationships with the insurance company where they can call and ask for a favor. Hey, I need you to rush this, and this is really urgent. I need you to get on this. They can apply pressure in certain areas that maybe an everyday person can't. They might have relationships at billing offices where they know who to call or which manager to talk to get something fixed right away. So if you are going to engage with a claims advocate to set both yourself and the claims advocate up for success, you want to make sure that you're prepared with some information. You want to make sure you have copies of your bills from the provider's office in hand, as well as copies of your explanation of benefits from the insurance company. So you're going to have two different types of documentation for the service in question, and you'll usually have to sign a HIPAA authorization form. And this is a form that gives the doctor or the facility or whoever that is permission to talk to somebody else who is not you, the patient, because they're going to fiercely safeguard your personal health information. And lastly, you need to have a general idea of where to start, right? Again, I recommend get really familiar with this so that way you know this is what happens when it looks right, so that I know what happens when it's wrong. You might not know exactly what's wrong, but you need to have a general idea of, okay, this service is not right, or this bill doesn't match my EOB. You need to have a specific instance of, hey, this is what I need help with. If you just bring a claims advocate paperwork and say, I don't know, that's not going to set you or the claims advocate up for success. So make sure that you have those three pieces of information along with your idea of where we can even get started to help you out. All right. I'm going to go ahead and open it up for questions. Again, my name is Arwen. I'm with Advanced Benefits. I hope you found this information to be helpful today. You are more than welcome to put questions in the Q&A, and I'd be happy to answer them for you. Otherwise, thank you so much for spending this time with me. I hope you found it valuable. And again, if you registered for this webinar, you will receive a follow-up email with the copy of the recording and a copy of the slide deck that you can reference back later, share with other team members, or to revisit in the future where maybe you don't need this information right now, but you're going to access services. And in 6 months from now, you're like, I need to refresh myself on what that gal talked about. So with that, thank you so much. I'm going to go ahead and hang out for just a little bit to answer any questions. If you don't have any questions, thank you so much for spending the time with me, and have a great day.